exam notes.
Yes, the cardiovascular physiology recalls. Good stuff.
Yay. And for those of you listening, this isn't just your basic high school anatomy lesson. These are the diagnostic muddy waters where aspiring surgeons are drilled on, well, the invisible forces keeping a patient alive right there on the operating table.
Exactly. We are looking at high-stakes clinical scenarios here. The mission today is to decode these so you can understand not just what happens when a normal heart beats, but the catastrophic domino effects when the plumbing or the wiring or the pressure sensors totally fail.
That's like a puzzle.
It really is. These surgical notes are brilliant because they force you to move past just rote memorization. They present the patient crashing in real time, and you have to instantly calculate the microscopic baseline deviations. By unpacking these scenarios with us, you'll get a profound, behind-the-scenes look at your own hemodynamic architecture.
So to understand this mechanical pump, we really have to start with the spark, right? Before any muscle fiber can even twitch, an electrical blueprint has to be drawn across the myocardium.
Absolutely. The source material spends a lot of time on the electrocardiogram, the ECG. But importantly, not just as a pattern recognition tool, it breaks down the actual movement of ions across the sarcolemma.
Which is super cool because, I mean, the ECG is ultimately just a voltmeter reading the skin, right?
Right. But it represents these massive coordinated shifts in cellular polarity. So the text starts with the P wave. That's the electrical vector of atrial depolarization.
Meaning the top chambers of the heart.
Yeah, exactly. This is the signal originating from the sinoatrial node, the SA node, spreading through the syncytium of the atria, commanding them to squeeze that final volume of blood down into the ventricles.
And then the signal hits the AV node, right? It travels down the bundle of His, and then we get to the main event.
The QRS complex, ventricular depolarization.
It's just a huge spike on the paper.
Because the mass of the ventricles is so huge compared to the atria, so the electrical voltage just spikes significantly higher.
Right. And following that massive discharge, the myocardial cells have to, reset their ion gradients to prepare for the next beat, don't they?
They do. And that repolarization of the ventricles gives us the T wave. Yeah. Now, the total duration of that ventricular action, from the start of the QRS to the very end of the T wave, is the QT interval.
The QT interval.
Okay. Yeah, it is the absolute timeline of ventricular systole and cellular recovery.
You know, the notes also mention this elusive U wave. They define it as the last remnant of ventricular repolarization associated with the papillary muscles or the Purkinje fibers. But where this gets really actionable for a surgeon is when the text explores electrolyte disturbances, altering this whole delicate timeline.
Right. The recalls get very specific here.
Yeah, there's a specific focus on hypercalcemia, so an elevated level of calcium in the blood. And the recall asks what that does, and the answer is it causes a shortened QT interval. But why does excess calcium physically shrink that electrical window? I mean, how does that work?
Well, to answer that, we have to look at the action potential of a single cardiac myocyte.
Yeah.
Because unlike skeletal muscle, cardiac muscle has a really pronounced plateau phase during its electrical firing.
A plateau phase.
Yeah. This plateau is maintained by a slow, sustained inward rush of extracellular calcium. So if a patient is hypercalcemic, the concentration gradient of calcium outside the cell is much steeper.
Oh, I see.
Yeah, so when those voltage-gated calcium channels open, the calcium just floods in much faster than normal.
Yeah.
The cell achieves its required internal calcium concentration way quicker. The plateau phase abruptly terminates early, and the cell moves straight into repolarization.
Wow, okay. So therefore, the entire QT interval shrinks.
Exactly. The heart is firing and resetting too fast at the cellular level.
That makes a lot of sense. So let's look at how physical architectural changes distort this wiring. There is a specific scenario in the notes, question 89, I think, concerning a patient preparing for surgery who suffers from mitral stenosis.
Ah, classic question.
Right. And the defining feature on their pre-op ECG is a bifid P wave in lead 2.
Yes, the bifid P wave.
So if the P wave represents the atria firing, why does a stenotic, completely diseased mitral valve, which, just to be clear, sits downstream from the left atrium, why does that cause the P wave to split into two distinct humps? Is it like a traffic jam?
That is a great analogy, actually. The electrical signal is basically a physical map of the muscle it travels through. Now, the mitral valve is the gateway between the left atrium and the left ventricle, and stenosis implies chronic calcification, so the valve is stiff and narrowed.
So it's super hard to push blood through it.
Precisely. To force blood through that restrictive opening, the left atrium has to generate significantly higher pressures. Over months and years of working against that chronic resistance, The muscle wall of the left atrium hypertrophies. It gets physically thicker and larger.
Oh, right. And because there is more physical real estate, the electrical wave just takes longer to travel across the left atrium.
You got it. In a normal, healthy heart, the right and left atria depolarize almost perfectly synchronously, so their electrical vectors merge into a single, smooth P wave on the ECG.
But with the thickened wall.
Right, with a hypertrophied left atrium, the right atrium fires on time, creating the first peak, but the enlarged left atrium is delayed, creating a second distinct peak, just a fraction of a second later.
Which gives you that double hump.
Exactly. This bifid shape is a classic marker of left atrial enlargement. Historically, they call it P-matrial.
P-matrial. Okay, so moving on. The surgical notes push even further into the control mechanisms of this wiring. They pose a scenario, I think it's recall question 11 or 12, questioning the specific nerve supply to the sinoatrial node, the SA node.
Right, and this is a really tricky one for candidates.
Yeah, because the options force the candidate to choose between, like, vagal fibers, sympathetic fibers, and the cardiac plexus. And the required correct answer is a cardiac plexus. Why is that?
Well, they're explicitly testing if you know that the plexus encompasses both. See, the SA node has intrinsic automaticity. It will actually fire on its own, even if it's completely isolated from the body.
Which is wild to think about.
It really is. However, in a living human, its intrinsic rate is constantly modulated by the autonomic nervous system. So the parasympathetic tone, which is driven by the vagus nerve via muscarinic receptors, that depresses the rate. It's the brake pedal.
And the sympathetic tone.
That's via beta-adrenergic receptors. And it accelerates the rate. It's the gas pedal.
Yeah.
The cardiac plexus is the anatomical junction box situated right at the base of the heart, where both of these opposing neural pathways converge.
Ah, so they form a meshwork before innervating the SA node.
Exactly. And understanding this dual supply junction is so critical when administering anesthesia because drugs often selectively block one pathway, leaving the other entirely unopposed.
Okay, so we have the spark, we have the neuromodulation, and the electrical vectors mapped out. But an electrical signal is completely useless without mechanical leverage, right?
Right. The spark needs to cause a squeeze.
So to transition from the wiring to the plumbing, the notes highlight a fundamental cellular trigger. In Recall Question 16, they emphasize that cardiac muscle contraction is initiated specifically by an influx of calcium through the sarcolemma.
Yes, and this is where cardiac physiology diverges sharply from skeletal muscle physiology.
How so?
Well, if you move your bicep, a somatic nerve fires, and the sarcoplasmic reticulum, which is the internal storage tank inside the muscle cell, it immediately dumps massive amounts of calcium to trigger the contraction.
Just boom, all at once.
Boom, exactly. But cardiac myocytes operate on a mechanism called calcium-induced calcium release.
Wait, calcium-induced calcium release? So it needs calcium to get calcium?
Precisely. The electrical spark opens the voltage-gated channels on the cell membrane, the sarcolemma. A relatively small amount of extracellular calcium trickles into the cell.
Okay.
But that initial trickle acts as a physical key. It unlocks the massive internal storage tanks, causing them to flood the cell with the calcium needed for the actin and myosin filaments to actually engage.
So without that initial influx from the outside, the heart simply will not beat.
It won't. It's a brilliant fail-safe mechanism that couples the electrical environment of the blood to the mechanical force of the muscle. And by the way, it is also the exact target of calcium channel blocker medications used to treat hypertension and arrhythmias.
Oh, really?
Yeah, by limiting that initial extracellular influx, we diminish the force of the subsequent contraction. Also, the notes astutely point out what cardiac cells cannot do. They present options suggesting cardiac cells divide to cause hypertrophy or that they have the capacity to regenerate.
I assume those are traps.
Absolutely false, both of them. Myocytes grow in size, they do not grow in number, and ischemic death results in permanent fibrotic scar tissue, period.
Wow. Good to know. Okay, so once that calcium floods the cell, we enter the mechanical cardiac cycle. The text zeroes in on a very specific fleeting moment. In Recall Question 10, it talks about the onset of isovolumic contraction, and it marks this phase as beginning exactly when the tricuspid and mitral valves snap shut.
Right. You can think of the cardiac cycle as a series of pressure gradients and locked room mysteries.
Locked room mysteries. I love that.
It's true. Isovolumetric means the volume of blood inside the chamber is completely static. So as the ventricular muscle begins to contract, the pressure inside the chamber sharply rises, instantly exceeding the pressure in the atria above it.
And that pressure differential is what slams the inlet doors, the mitral and tricuspid valves shut.
Exactly. But here's the catch. The pressure inside the ventricle hasn't yet surpassed the immense diastolic pressure resting out in the aorta and the pulmonary artery.
So the exit doors remain closed, too.
Yes. For a fraction of a second, the ventricle is a sealed vault. Both doors are locked. The myocardium is contracting with violent force against an incompressible fluid. The pressure skyrockets vertically on a graph, but because no fluid can leave, the volume remains completely unchanged.
So it's like revving a highly tuned car engine while the emergency brake is fully on.
That is a perfect way to visualize it.
You are burning metabolic fuel, you're generating immense torque, but there is zero forward movement. You are strictly building the necessary force to overcome the systemic resistance.
Right. And once the ventricular pressure finally exceeds the aortic pressure, boom, the aortic valve is blown open and the ejection phase begins.
And the notes mirror this on the back end with isovolumic relaxation, don't they?
They do. After ejection, the ventricle begins to repolarize and relax. The pressure drops, causing the aortic and pulmonary valves to snap shut, which prevents backflow.
But the ventricular pressure is still temporarily higher than the atrial pressure, keeping the inlet valves closed again.
Exactly. Once again, a sealed vault. The muscle tension dissipates, pressure plummets without any change in volume until it finally falls below the atrial pressure, which pops the inlet valves open to begin the filling phase.
This mechanical symphony dictates the primary mathematical output of the body. So let's get into the math. The source material drills down into calculating cardiac output. Specifically, recall questions 87, 17, and 18. They provide the core formula, which is stroke volume multiplied by heart rate.
Yes, CO equals SV times HR.
Right. So they walk through this specific patient scenario. The patient has a heart rate of 72 beats per minute, an end diastolic volume of 150 milliliters, and an end systolic volume of 80 milliliters. And they ask you to calculate the output.
Right. So the calculation requires deriving this stroke volume first. End diastolic volume, or EDV, is the absolute maximum capacity of the ventricular tank just before contraction. So in this case, 150 milliliters.
Okay, and end systolic volume, ESV.
That is what remains in the tank after the squeeze is complete. The ventricle never empties completely, Here, 80 milliliters remain.
So you just subtract them. The difference between the two 150 minus 80 is 70 milliliters. So that is the actual volume ejected per beat, the stroke volume.
Exactly. You have your 70 mil stroke volume. Now you multiply that by the heart rate of 72 beats per minute. That yields roughly 5,040 milliliters, or a standard cardiac output of about 5 liters per minute.
It seems like such simple arithmetic, like basic subtraction and multiplication. But this equation is basically the razor's edge of surgical survival, isn't it?
It absolutely is,
Epic.
because it exposes exactly how the body's compensatory mechanisms operate. Let's say venous return drops due to massive hemorrhage. End diastolic volume plummets. The tank doesn't fill. Consequently, stroke volume drops. But the body desperately needs to maintain that vital 5 liters per minute of cardiac output to perfuse the brain. So the brain has only one variable left in the equation to manipulate.
The heart rate?
Exactly. Heart rate goes up. Tachycardia is very often the absolute first clinical sign that the mechanical volume of the system is failing.
That is so elegant. Let's apply this math to a truly fascinating anomaly from the surgical recalls. Recall question 3. There is a case of a 57-year-old heart transplant recipient who begins a moderate exercise program. And the question asks, what physiological factor is most likely responsible for increasing their cardiac output during this exertion?
Yes, and the correct option they want you to select is increased atrial filling.
But why?
This is an elegant test of applied physiology because it strips away the autonomic nervous system entirely.
Oh, because it's a transplant?
Right. During a heart transplant, the surgeon excises the native heart, severing the vagus nerve and the sympathetic nerve fibers from the cardiac plexus we discussed earlier. The donor heart is implanted, but those neural pathways, they do not reconnect.
So the transplanted heart is effectively flying blind. It's devoid of the brain's real-time chronotropic and inotropic commands.
Completely. When this patient starts jogging, their motor cortex demands more oxygen, but the transplanted SA node doesn't get the memo to speed up. Not immediately, anyway.
So how do they not just pass out? A normal person relies on sympathetic tone to instantly spike their heart rate at the onset of exercise, right?
Right. But the transplant patient must rely entirely on intrinsic myocardial mechanics, specifically the Frank-Starling law of the heart.
Okay, break that down for me.
Sure. As the patient exercises, the rhythmic contraction of their skeletal muscles in their legs systematically squeezes the venous capacitance vessels. This forces a massive surge of blood back toward the right atrium.
Ah, venous return surges, which means the end diastolic volume drastically increases. The tank essentially overfills.
Exactly. The influx of volume physically stretches the myocardial fibers of the ventricle. And, at a microscopic sarcomere level, this stretching optimizes the physical overlap between actin and myosin filaments, which actually increases their affinity for calcium.
Wow.
Yeah, so the further the cardiac muscle is stretched by incoming blood, the more forceful the subsequent contraction will be. It is a purely mechanical, intrinsic property of the tissue.
So this increased atrial filling directly enhances the stroke volume, thereby elevating the cardiac output entirely independent of neural input.
Exactly. Minutes later, circulating catecholamines like adrenaline released from the adrenal glands will finally reach the donor heart via the bloodstream and increase the heart rate. But the immediate survival response is purely Starling's volume stretch mechanism.
It is localized, decentralized engineering at its finest. I love that. But of course, when the mechanics degrade, the results are devastating. Let's look at recall question 24. The notes present a 30-year-old male admitted with an absent pulse in his right upper limb.
A classic and scary presentation.
Yeah. Examination reveals atrial fibrillation. The recalls ask for the underlying disease association, and you have to identify a left atrial thrombus.
Right. Atrial fibrillation represents the total collapse of the electrical spark we mapped out earlier. The sinoatrial node is overwhelmed by chaotic, completely disorganized electrical impulses firing randomly throughout the atrial syncytium.
So instead of a coordinated, powerful contraction, the atrial walls merely fibrillate. They just quiver.
They do. The atria lose their mechanical kick. They are no longer actively pumping blood into the ventricles. They just act as passive vibrating conduits.
Which invokes Virchow's triad, doesn't it? The three factors that contribute to thrombosis.
Exactly. And the most critical factor here is stasis of blood flow. When blood ceases to move dynamically, particularly in this little trabeculated pouch known as the left atrial appendage, it coagulates, a thrombus forms.
A blood clot. And the catastrophe occurs when a fragment of that organized clot breaks loose.
Yes. It is drawn into the left ventricle, ejected through the aortic valve, and it enters the systemic arterial circulation as an embolus.
And in this 30-year-old patient's case, it traveled up the aortic arch, bypassed the carotids, and lodged firmly in the right subclavian or axillary artery, entirely occluding flow to the right arm, hence the abolished distal pulse.
It perfectly illustrates how an electrical firing error rapidly degrades into a catastrophic mechanical obstruction. And it really underscores why managing atrial fibrillation is rarely just about rate control. Aggressive anticoagulation is paramount to prevent the left atrium from becoming an embolic factory.
That is terrifying. Okay, so all of this mechanical exertion-generating pressures high enough to perfuse the brain and body requires an immense metabolic supply to the myocardium itself.
It does. It's a very hungry muscle.
Which brings us back to that physiological paradox we opened the show with. Coronary perfusion. The notes explicitly state that coronary flow occurs mainly during diastole.
Yes. To understand this, you really have to visualize the structural origin of the coronary arteries. They emerge from the aortic root, positioned just millimeters above the leaflets of the aortic valve. During ventricular systole, the left ventricle generates pressures exceeding 120 millimeters of mercury. This immense wall tension literally compresses the intramyocardial blood vessels, clamping them shut.
Wow. So the muscle is squeezing so violently that blood physically cannot penetrate the vascular beds within the ventricular wall, regardless of how high the aortic pressure is.
Exactly. It is only when the ventricle repolarizes and enters diastole that the myocardial tension relaxes. The aortic valve snaps shut, and the elastic recoil of the aorta maintains a high driving pressure.
So it's that pressure gradient.
Right. The aortic diastolic pressure minus the now negligible left ventricular pressure. That gradient forces oxygenated blood backward into the coronary ostia, flooding the relaxed vascular beds of the heart muscle.
The implications of this are laid bare in a critical recall scenario. Question 15. We have a 53-year-old man, a heavy smoker with chronic hypertension, presenting with crushing chest pain at rest.
A very typical ER presentation.
Yeah. His heart rate is screaming at 138 beats per minute with a blood pressure of 140/90. The question asks for the principal cause underlying his reduced coronary blood flow among a list of options, and the correct answer you have to pick is decreased diastolic interval.
Because as heart rate accelerates, the duration of the entire cardiac cycle condenses. However, the compression is asymmetrical. The mechanical act of ventricular contraction systole is relatively fixed. I mean, muscle fibers can only shorten so quickly.
Right.
Therefore, nearly all the time sacrificed during tachycardia is subtracted from diastole.
So at 138 beats per minute, the heart is spending the vast majority of its time clamped shut in systole, actively crushing its own blood vessels. The relaxation phase, which is the only window where the coronaries can fill, is just decimated.
The heart is actively starving itself. Furthermore, a heart beating at 138 beats per minute is consuming exponentially more ATP and oxygen just to maintain that kinetic output.
Oh, right, so it's a double whammy.
It is. The myocardium is caught in a lethal intersection. Metabolic demand is skyrocketing precisely at the moment when the anatomical window for oxygen delivery is shutting. This profound supply-demand mismatch induces severe myocardial ischemia.
Which manifests clinically as that crushing angina he's feeling.
Exactly.
But we know the body attempts to self-regulate, right? The notes mention coronary autoregulation in question 93. They point to a scenario of a 50-year-old experiencing chest pain during a stress ECG. It asks what substance mediates this autoregulation, and the answer is lactate.
Yes, under extreme exertion, when oxidative phosphorylation cannot keep pace with the heart's energy demands, the myocytes basically shift into anaerobic glycolysis.
They start burning fuel without oxygen.
Right. And a primary byproduct of this desperate metabolic pathway is lactic acid, or lactate. The accumulation of lactate in the myocardial interstitial fluid acts as a potent, localized distress signal.
What does it do?
It directly induces vasodilation in the adjacent coronary arterioles. It chemically forces the vessels to widen in an attempt to pull more blood flow into the ischemic territory. It is an intrinsic metabolic survival reflex.
But, I mean, that reflex is completely useless if the pipes are structurally compromised, isn't it?
Exactly. You can dilate all you want, but if there's a physical blockage, it won't matter.
Which brings up recall question 92. It highlights a 40-year-old with familial coronary artery disease, linking the genetic defect specifically to apolipoprotein B.
Yes, apolipoprotein B is the primary structural protein scaffolding for low-density lipoprotein, or LDL particles, your bad cholesterol.
Right.
A genetic defect here impairs the hepatic clearance of these cholesterol-rich particles from the bloodstream. So they just circulate and they permeate the endothelial lining of the coronary arteries, triggering a chronic inflammatory cascade that culminates in calcified atherosclerotic plaques.
And if the lumen of the coronary artery is physically occluded by a rigid plaque, no amount of localized lactate can force it to dilate. The architectural integrity is just destroyed.
Precisely. Which forces physicians to have to hack the system pharmacologically.
Okay, let's get into the drugs. The source material outlines several scenarios focusing on receptor targets, specifically isoprenaline and dobutamine acting on beta-1 receptors located in the ventricles, producing an inotropic effect.
Right. The autonomic nervous system utilizes very specific receptors to elicit precise responses. Beta-1 adrenergic receptors are concentrated heavily in the ventricular myocardium.
Okay.
When an agonist, like dobutamine, binds to them, it triggers an intracellular cascade that ultimately increases the influx of calcium during the action potential. And as we learned earlier, more calcium equals a more forceful contraction.
A positive inotropic effect.
Exactly.
But let's push back on this logic for a second. We just established that making the heart work harder increases its metabolic demand and its oxygen consumption.
We did.
Right. So in one of the recalls, a 50-year-old patient is in cardiogenic shock due to myocardial ischemia, a heart attack. The pump is failing. The notes indicate dobutamine is the correct choice over adrenaline. But wait, if dobutamine makes the ischemic heart pump harder, aren't we just exhausting a dying pump by jacking up its oxygen demand?
That is the exact physiological tightrope the physician is walking in the ICU. Yes, increasing inotropy inevitably increases myocardial oxygen consumption. But in cardiogenic shock, the forward flow of blood has collapsed so profoundly that the body's organs, including the heart itself, are dying from lack of perfusion pressure.
So you have to do something.
You must restore forward flow. The choice of dobutamine over adrenaline comes down entirely to afterload, the resistance the heart must pump against.
Oh, because adrenaline doesn't just hit the heart.
Correct. Adrenaline is a potent agonist of alpha-1 receptors, which are found densely packed in the peripheral blood vessels. Activating alpha-1 causes massive systemic vasoconstriction.
Wow, okay.
So if you administer adrenaline to a failing ischemic ventricle, you certainly increase its contractility, but you simultaneously clamp down the entire arterial system. You force that weakened heart to push against a sudden massive wall of resistance.
And the increased afterload probably just outweighs any inotropic benefit.
It does. It leads to rapid pump failure.
So dobutamine is a precision tool. It selectively hits the beta-1 receptors in the ventricle to strengthen the squeeze, but it has negligible alpha-1 activity, meaning it doesn't constrict the blood vessels.
Precisely. It may even cause mild vasodilation via beta-2 receptors, slightly lowering the afterload.
So the failing heart gets a power boost without facing a brick wall of systemic resistance.
Right. The trade-off of increased oxygen demand is deemed acceptable simply because it restores the gross cardiac output necessary to keep the patient alive.
That is fascinating. But pharmacology has hard limits when confronted with structural doom. Let's look at recalls 55 through 78. Two separate recall scenarios ask to identify the most risky pre-existing condition for a patient undergoing general surgery.
Oh, the anesthesia nightmare scenarios.
Yeah. The options include various valvular diseases, mitral stenosis, aortic regurgitation, stuff like that. But the undisputed worst-case scenario, the correct answer, is aortic stenosis. Why does aortic stenosis terrify anesthesiologists more than, say, a failing mitral valve?
Because it represents a catastrophic vulnerability in the fundamental equation of blood pressure. Aortic stenosis is the calcification and severe narrowing of the primary exit valve of the heart. The left ventricle must generate terrifyingly high pressures, sometimes exceeding 200 millimeters mercury, just to force a normal stroke volume through that pinpoint opening.
And to do that, the ventricular myocardium undergoes massive concentric hypertrophy. It gets incredibly thick to generate this force.
Right, which means it requires a massive amount of oxygen just to survive at baseline.
Okay, so now introduce general anesthesia.
Right. Nearly all induction agents and volatile anesthetics inherently depress myocardial contractility and, crucially, cause profound systemic vasodilation. Systemic vascular resistance drops, causing the patient's blood pressure to plummet.
In a normal patient, the baroreceptors would sense this drop, the heart rate spikes, and the stroke volume increases to refill the arterial tree and restore pressure, right?
But the patient with critical aortic stenosis has a fixed stroke volume. The stenotic valve physically restricts any increase in forward flow. The heart simply cannot pump more blood out, regardless of how fast it beats.
Oh, wow.
Yeah, so when the anesthetic vasodilates the systemic vessels, the pressure in the aortic root just collapses.
And as we established earlier, coronary perfusion pressure relies entirely on the diastolic pressure in that aortic root.
That is the lethal spiral. The massive, oxygen-hungry, hypertrophied ventricle suddenly loses its drive and perfusion pressure because the aorta is empty. Ischemia sets in within seconds.
And then what?
The ischemic muscle fails, cardiac output drops further, aortic pressure drops further, and coronary perfusion ceases entirely. The patient spirals into ventricular fibrillation and cardiac arrest. It is a rapid, mechanically fixed hemodynamic collapse that is notoriously difficult to resuscitate.
That is chilling. Understanding this plumbing dictates every single maneuver in the OR. But, the cardiovascular system isn't operating blind either. It monitors its own parameters through a highly sophisticated network of pressure and volume sensors.
It does. It has an incredible feedback loop.
Let's look at how these sensors dictate physiology and how surgeons read them. The notes detail the jugular venous pulse, the JVP, breaking down the alphabet soup of waveforms visible in the neck veins.
Right. The internal jugular vein acts as a direct, valveless manometer communicating directly with the right atrium. By observing the pulsations in the neck, a physician is essentially watching the mechanical events of the right side of the heart play out in real time.
So let's decode the waves.
Sure. The A wave corresponds to atrial contraction. The C wave is a slight interruption caused by the bulging of the tricuspid valve into the atrium during the onset of ventricular systole. The X descent reflects atrial relaxation. The V wave is the passive venous return filling the right atrium while the tricuspid valve is closed. And the Y descent is the rapid emptying of blood into the right ventricle when the tricuspid valve finally opens.
Okay, and the notes specifically highlight pathological deviations here. They point out that giant V waves are indicative of tricuspid regurgitation.
Yes. If the tricuspid valve leaflets fail to coapt, if they are leaky, then during ventricular systole, The immense pressure generated by the right ventricle doesn't just push blood forward into the lungs.
It shoots a high-velocity jet of blood backward.
Exactly, backward through the incompetent valve into the right atrium. This violent surge of regurgitant volume forcefully travels retrograde up the superior vena cava and into the jugular veins precisely during the V-wave phase.
Creating a massive, visible systolic pulsation in the
A
neck.
giant V-wave, yes.
The text also mentions canon A waves, linking them to complete heart block and ventricular tachycardia. This implies like a physical collision of sorts.
It is. It's a profound disruption of the atrioventricular synchrony. In complete heart block, the electrical signal from the SA node fails entirely to reach the ventricles. The atria and ventricles begin beating completely independently, driven by separate pacemakers at different rates.
Oh, I see.
So occasionally, the independent atrial pacemaker fires, commanded the right atrium to contract forcefully, at the exact simultaneous moment that the independent ventricular pacemaker has commanded the right ventricle to contract.
So the atrium tries to push blood downward, but the tricuspid valve is already slammed shut by the high pressure of the ventricular contraction beneath it.
The atrial contraction hits a literal brick wall. The blood is forcefully ejected backward up into the jugular system, creating a booming, intermittent cannon wave visible to the naked eye.
It's a striking physical manifestation of electrical dissociation. Those are the visible alarms. But the notes also explore the internal sensors that adjust the system autonomously. There is a classic trauma scenario presented in Recall Question 23. A 26-year-old motorcyclist loses a full liter of blood following an open femur fracture.
A huge volume loss.
Right. And the question asks to identify the absolute earliest compensatory response to this hypovolemia. The options range from capillary fluid shifts to the renin-angiotensin system, but the correct answer is baroreceptors-induced venoconstriction.
In trauma, timelines are everything. Endocrine responses like the renin-angiotensin-aldosterone system, they take minutes to hours to synthesize and enact fluid retention at the renal level. The body needs an instantaneous defense against hemorrhagic shock.
And that's the baroreceptors.
Yes, they are specialized mechanoreceptors embedded in the adventitia of the carotid sinuses and the aortic arch.
So these sensors are constantly stretched by the pulsatil pressure of the blood. But when the motorcyclist loses a liter of volume onto the pavement, his arterial pressure drops and the stretch on these receptors instantly diminishes.
Right. That loss of stretch sharply decreases the firing rate of the afferent nerves traveling to the medullary cardiovascular center in the brainstem. The medulla perceives this as a critical threat and instantaneously withdraws parasympathetic tone while unleashing a massive efferent sympathetic discharge.
And the most crucial immediate target of this sympathetic surge isn't just the heart, is it? It's the venous system.
Exactly. Because the veins aren't just passive return pipes, they are active capacitance vessels. They hold roughly 60 to 70% of the body's total blood volume at any given time.
Wow, 70%.
Yes. So the sympathetic discharge causes profound venoconstriction. The smooth muscle in the walls of the massive venous reservoirs like in the splanchnic bed and the extremities clamps down.
This literally squeezes the remaining blood out of the venous capacitance system and shifts it into the central arterial circulation.
It is an internal physiological autotransfusion designed to rapidly restore right atrial filling pressure, salvage the end diastolic volume, and maintain cardiac output to the brain and heart. And it happens in milliseconds.
Milliseconds. That's incredible. Now, what happens when a surgeon inadvertently triggers these reflex arcs? There is a scenario in Recall 88 detailing a laparoscopic appendectomy.
Yes.
The surgeon inserts a port under direct vision, and the patient suddenly suffers a massive drop in heart rate and blood pressure, bradycardia, and hypotension. The cause identified is vagal stimulation.
The peritoneum, the membrane lining the abdominal cavity, is richly innervated by the vagus nerve. And the vagus nerve is the primary conduit of the parasympathetic nervous system.
Right, the brake pedal.
During laparoscopic surgery, the sudden aggressive mechanical stretching of the peritoneum by the insertion of a trocar, or the insufflation of carbon dioxide gas, can trigger a profound reflex arc.
So the stretch receptors fire up the efferent pathway to the medulla, and the brain accidentally interprets this as a command to slam on the parasympathetic brakes.
Exactly. The efferent vagal signal floods the sinoatrial and atrioventricular nodes with acetylcholine. the heart rate plummets. Since cardiac output equals stroke volume multiplied by heart rate, having the heart rate instantly halves the cardiac output.
Precipitating a sudden hypotensive collapse right there on the operating table.
Exactly. The immediate intervention requires the surgeon to release the physical traction immediately, and the anesthesiologist to administer an anticholinergic drug like atropine to block the muscarinic receptors and basically release the vagal brake.
Wow. We don't just trigger reflexes, we physically alter the pressure gradients of the chest itself through life support. Recall question 4 focuses on a 20-year-old with a severe head injury placed on a mechanical ventilator using intermittent positive pressure ventilation, or IPTV.
A very common ICU scenario.
Yeah. And the question asks for the primary physiological consequence, landing on decreased venous return and decreased cardiac preload.
This requires a shift in how we understand respiration. Spontaneous physiological breathing operates on negative pressure. When your diaphragm contracts and moves downward, it expands the thoracic cavity, creating a subatmospheric vacuum.
This negative pressure draws air into the lungs, but crucially, it also acts as a vacuum pump on the vena cava, literally sucking venous blood from the lower body up into the right atrium.
It actively assists venous return. But mechanical ventilation flips the physics entirely.
I imagine it like trying to pump water into a sealed submarine that is already highly pressurized. IPPV forces air into the lungs under positive pressure.
That positive pressure is transmitted throughout the intrathoracic cavity. The vena cava, being thin-walled, low-pressure vessels, are physically compressed by this increased ambient pressure within the chest.
So the pressure gradient between the peripheral veins and the right atrium is significantly narrowed.
Right. The submarine is pressurized, so the water from the outside struggles to flow in. Venous return is impeded.
And following the domino effect we've mapped out today, decreased venous return leads directly to decreased end diastolic volume, the preload.
And according to Starling's law, a lower preload results in diminished sarcomere stretch, a weaker contraction, a reduced stroke volume, and ultimately a fall in cardiac output. Intensive care physicians must constantly titrate the positive and expiratory pressure on the ventilator against the patient's intravascular volume status to prevent iatrogenic shock.
Which brings us to the ultimate catastrophic terminus of all this: system overload, shock, trauma, and hemodynamic collapse.
The deep end.
We've seen how the body compensates through baroreceptors, venoconstriction, and tachycardia. But what happens when compensation reaches its absolute limit and the patient crosses into actual shock? The notes categorize shock not by the initial injury, but by the mathematical footprint of the failure.
Right. Shock is the unifying pathway of death. It is the state of profound systemic tissue hypoperfusion leading to cellular hypoxia and anaerobic metabolism. The source material contrasts several distinct profiles of hemodynamic collapse. Let's examine sepsis first.
Okay, so the recalls present 2 cases for this. Recall 43 and 44, a 58-year-old post-appendectomy, and a 9-year-old presenting in the ER with shivering. The candidate must identify the correct physiological parameters from a table. The signature profile for septic shock is defined as heart rate elevated, systemic vascular resistance decreased, and cardiac output initially elevated.
Because sepsis represents distributive shock. The fundamental failure here is not the pump, and it's not the blood volume, it's the tone of the pipes.
Ah, okay.
A massive unchecked infection triggers a systemic inflammatory response. The immune system releases a cytokine storm mediators like nitric oxide and prostaglandins that induce profound global vasodilation of the arterioles and capillary beds.
The pipes lose all their muscular tone and are thrown wide open. The resistance plummets, which is why systemic vascular resistance is marked as decreased.
Yes. The vascular container is essentially doubled in size, but the volume of blood remains exactly the same. The pressure collapses. The baroreceptors, sensing this profound hypotension, initiate massive sympathetic drive.
So the heart rate accelerates intensely.
And because the left ventricle is now pumping against virtually zero systemic resistance, the afterload is basically gone, it is incredibly easy for the heart to eject blood. Therefore, the total volume of blood moving per minute, the cardiac output, actually increases initially.
This creates the paradox of warm shock, doesn't it? The patient's skin is flushed, warm, and bounding with high cardiac output, yet their organs are actively dying.
Yes, because the microcirculation is completely deregulated. The blood is shunted rapidly through the dilated capillaries without exchanging oxygen at the tissue level. It is a state of hyperdynamic failure.
That is the complete failure of the pipes. Now let's contrast that with the failure of the pump itself. Cardiogenic shock. Recalls 2 and 91 detail a 60-year-old with a history of angina who undergoes a hernia operation. Postoperatively, he is hypotensive, tachycardic, and exhibits a raised jugular venous pressure. The primary cause identified is reduced stroke volume.
The surgical stress likely precipitated a massive myocardial infarction, a heart attack. A significant portion of the left ventricular myocardium becomes ischemic, dies, and transitions into a dyskinetic, flabby scar. The pump has fundamentally lost its contractility.
The ejection fraction plummets, meaning the stroke volume collapses, and the math is brutal. Low stroke volume equals low cardiac output, resulting in severe hypotension.
The sympathetic nervous system responds predictably by driving the heart rate up, resulting in tachycardia. But the defining feature that differentiates this from hypovolemic shock is that elevated JVP.
Because the left ventricle cannot eject blood effectively forward, so the diastolic pressure within the ventricle rises.
Exactly. This pressure backs up sequentially into the left atrium, the pulmonary circulation, the right ventricle, and ultimately the right atrium and the jugular veins.
The fluid is backing up behind the failing pump, and the notes highlight an even more catastrophic subset of cardiogenic shock. A patient with an inferior myocardial infarction requires the emergency placement of an intra-aortic balloon pump due to a papillary muscle rupture.
Oh, this ties back beautifully to our early discussion of the ECG and the U-wave. The papillary muscles are the muscular pillars anchoring the chordae tendineae, which hold the mitral valve leaflets shut against the immense pressure of ventricular systole.
Okay.
The posteromedial papillary muscle, which is often supplied by a single branch of the right coronary artery, is exquisitely vulnerable to ischemia during an inferior MI.
So if that muscle tissue infarcts and necroses, the physical pillar just snaps.
It is an explosive mechanical failure. During the next ventricular contraction, there is absolutely nothing anchoring the mitral valve. The leaflets are blown completely backward into the left atrium.
A massive portion of the stroke volume is violently regurgitated backward into the low-pressure pulmonary system instead of forward out the aorta.
The patient basically drowns in flash pulmonary edema while systemic cardiac output drops to near zero. The intra-aortic balloon pump, or IABP, is a mechanical counterpulsation device inserted into the aorta. It inflates during diastole to force blood into the coronaries and rapidly deflates just before systole to create a vacuum, drastically reducing afterload to help the struggling ventricle push blood forward.
Wow. Finally, the surgical recalls confront the candidate with the most acute, dramatic presentation of all, obstructive shock. Recalls number 9 and 71 highlight this. A female 9 days post-chest trauma presents shocked with a raised JVP, diagnosed as a hemopericardium, and a 30-year-old man suffers blunt chest trauma in a car accident, presents with hypertension, raised JVP, muffled heart sounds, and arrests within 15 minutes.
Awful.
Yeah. The specific physiological mechanism of his cardiac arrest is identified as reduced RV diastole.
Both scenarios describe cardiac tamponade. The heart is encased in the pericardium, which is a tough, fibrous, relatively inelastic sac. If blunt trauma lacerates a coronary vessel or the myocardium itself, blood hemorrhages into this sealed potential space between the heart and the pericardial sac.
And because the fiber sac cannot stretch rapidly to accommodate this accumulating volume, the pressure within the pericardial space rises exponentially with every single milliliter of bleeding.
And we must return, once again, to the absolute necessity of diastole. For the heart to pump, it must first relax, expand, and passively fill with venous return. But as the external pericardial pressure mounts, it eventually exceeds the internal diastolic filling pressures of the cardiac chambers.
So the heart is mechanically compressed from the outside.
The thin-walled right ventricle is the most vulnerable point in the whole system.
Why the right ventricle specifically?
Because the right ventricle operates at much lower pressures than the left. It is easily crushed by the external tamponade. During diastole, the right ventricle is physically prevented from expanding. This is the reduced RV diastole they're looking for on the test. If the right ventricle cannot expand, it cannot accept venous return.
And if venous return cannot enter the right heart, the preload drops to zero, stroke volume drops to zero, cardiac output collapses, and the patient goes into pulseless electrical activity and arrests.
And the diagnosis relies on recognizing Beck's triad, which was perfectly outlined in the trauma scenario. Profound hypotension due to the loss of cardiac output, a massively elevated JVP because venous blood is hitting the physical roadblock of the compressed right heart, and muffled heart sounds because the clinician is attempting to auscultate the closing of the valves through a dense layer of trapped, pressurized blood.
And what's the fix?
The only intervention is immediate surgical decompression. A needle or scalpel straight into the pericardial sac to release the trapped blood and allow the heart to expand.
It is truly remarkable how these seemingly sterile exam questions trace the precise edge of human mortality. I mean, we began today by examining the flow of microscopic calcium ions opening voltage-gated channels on a single sarcolemma.
Right.
We mapped the electrical vectors that command the syncytium to fire. We deconstructed the mathematics of isovolumic contraction, stroke volume, and the paradox of the heart basically starving itself of oxygen just to keep the aortic root pressurized.
That's all connected.
And we witness the systemic collapse when the baroreceptors lose their grip, when the vagus nerve is suddenly stimulated, or when the entire organ is crushed within its own pericardial sac.
The through line connecting all these scenarios is the relentless mechanical logic of the cardiovascular system. It is a system of immense power governed by microscopic tolerances. Understanding it requires moving way beyond just basic anatomy and into fluid dynamics, electrical engineering, and cellular metabolism.
Which leaves me with a final thought for you to consider. We've meticulously mapped the physics today. We understand exactly how venous return alters end-diastolic volume through actin myosin overlap. We can chemically manipulate contractility with targeted beta-1 agonists like dobutamine while preserving systemic vascular resistance.
We have the tools.
Right. The variables of the equation are known. So if the mathematics and the mechanics are so explicitly understood, how far are we from a fully autonomous, permanent artificial heart? Can a mechanical turbine ever truly replicate the instantaneous, localized, neurohumoral symphony of a biological heart adjusting to a liter of hemorrhagic blood loss in milliseconds?
That's the million-dollar question.
Or is the biological cardiovascular system a masterpiece of wetware engineering that we are destined only ever to support rather than truly replace? Think about the sheer complexity of that engineering the next time you feel your pulse.